All right. Good afternoon, everybody. This is Julian Marsden. I just want to welcome you to our inaugural E2E WEDOC webinar for 2013. We're very fortunate today to have Dr. Drew Signey from Nanaimo speaking to whose system is it anyways, and I think it's a very appropriate talk to give as our first one. And before we get into that, I just want to do some advertising what's coming up. And this, there's a couple things that I'd like people to know about. One is the Quality Forum 2013, which is February 27th to March 1st. It's the second one we've held, and it's a good-sized conference. It's very well done last year, and from the agenda looking at it this year, it's going to be extremely important to attend if you have any interest in quality and safety. So please put that into your calendars and think of attending this. You can go to www.qualityforum.com for information.
I did. You will do.
Okay. Please, Next thing I want to remind you is that this is part of the WEDOC, which stands for Western Emergency Department Operations Conference, and that will be held this year in Calgary. It's the fourth time we're holding it, and it goes between Edmonton, Vancouver, and Calgary. And this year it'll be April 26th and 27th in Calgary, and that information is also up at the University of Calgary, and also you can see it there as well. The next thing that you should know about is certainly for those in the emergency department and ICU and anybody dealing with sepsis, is the BC Sepsis Network is part of the clinical care management. The next webinar is on this Monday, the 21st, at 9:15, and if you wish, you can go to this same website here and log on to that training session, and you will be able to, for 45 minutes, Dr. Stephen Reynolds will be educating us around the role of procalcitonin and its use and hopefully potential use in decreasing the amount of antibiotics we use. So lots of things going on. The next webinar for the E2E WEDOC seminars will be in 2 weeks, and it's entitled Health System Accountability, What, Who, and How. It's a panel discussion. It's on Thursday this afternoon, and our three panelists are Mary Atkinhusen, who's the Chief Operating Officer of Vancouver Coastal, Grant Innes of Emergency Medicine at the University of Calgary, and Dr. Les Vertesi, who's the Executive Director of BC Health Services Purchasing Organization. Be very knowledgeable, excellent speakers who will take this topic and look at it in a very interesting way. So please join us then. I'm going to hand over to Drew.
Oh.
Very fortunate today to again, as I said before, start out with a bang. Drew Signey, who's been around working in emergency departments for many years now, has had many leadership roles and has really come to really understand what needs to happen in the system from a system point of view. And we're very fortunate to have somebody who's been really not just talking the talk, but walking the walk. And so, Drew, I'm really thankful for you for doing this, and I'll just hand over the presenter controls to you now and let you take it away.
Thank you very much, Julian. First of all, can everybody hear me okay out there?
Yes.
Or am I muted? Am I live and we're good? Okay. So just so you know, we okay, Julian?
Yeah. Sorry, one last thing before I forget. If we'll have to mute people who are listening because it gives a lot of feedback. So we'll mute you. If you wish to ask a question, there's a couple of ways of doing it. One is on the right-hand panel, you'll see the hand that's raised. If you click on that, we will see that, and we will, at an appropriate time, bring attention to you so you can ask your question or make your comment. The other thing you can do is type in a comment into the chat box or a question into there, and we'll get to that as well. So before you did that, before you talk, I just wanted to let people know about this, as we will have to mute everybody online. So thank you.
Perfect. And just so everyone knows, we are doing a first at E2E where we're actually doing a live presentation as well as on the webinar. So there's a room of 13 people in front of me who can't hear what's going on other than just me talking. So it's we're going to see how this works. So it'll be kind of fun. So I need to slide over. Pardon the pun. Shameless marketing for WEDOC once again. and you've already heard all that, so I don't need to go into that, and we'll just get into the meat of the matter. So we always have to have an objective slides around systems design and any kind of talk. So this really is, first of all, to try and define a system. So those are a WEDOC. I'll apologize because I did talk a little bit about this then, but it is nothing like repetition to drill something home and get it cemented in your head. So I'll promise I'll do that fairly briefly. I'm going to try and present some arguments that we actually don't have a healthcare system, rather we have a healthcare sector that desperately would like to be a system and absolutely needs to be a system in order to be successful. Trying to embed some understanding of why not having a responsive system is, I think, one of the greatest quality failures we have, and really needs to be put at the top of that agenda. I had an interesting question from a colleague at our MAC, Medical Advisory Committee, who said, well, what is it, Drew? Is it flow or is it quality? And my response was, they're not mutually exclusive. They are actually bundled together, and I've got some data to show that. Start some thinking around the barriers. What are some of the problems and we face, and why are we having trouble getting to this system view? And a couple of concepts I'd like to throw out there for people to chew over. And then some examples of where the power of systems thinking has made incredible and profound changes on the delivery of care for patients. So we're going to try and get through all that in a fairly expedited manner. So the first thing is, well, what is a system? Well, this is a fairly famous quote that's gone around. Don Berwick is the president of the IHI and the various other notable areas in the United States. So every system produces the results it's designed to produce. My corollary is that this system was actually never designed. We've never sat down and actually started from scratch, torn it completely apart and pulled it back together again in a logical format. It's really been evolving over decades and decades and decades, and as new things come up, we just sort of stick them on the side somewhere, and we don't actually think it through and do it in a logical way. So it's kind of why we're a little bit in the pickle that we're in. So there's lots and lots of various very complicated definitions. My rule is usually to have one word or two words per slide. So to cut to the chase, this was the best one that I can't remember a paragraph of anything. So I try and think of a system as this interacting and or interdependent components forming some kind of integrated whole. So the pieces are important, but the pieces are simply part of that integrated whole, and usually they have some relationship. And that is an important concept as we sort of start looking at it and comparing it to the healthcare sector. What are the characteristics of a system? Again, these are all very important. They have structure, there's components, there's bits and pieces to it, there's inputs and there's processes and there's data and all the things we get down to. But the part that I think is, again, most important, all of those are key, but the most important thing is some kind of common goal. And I believe that part of our problem is we have, although we're all here for the same reason, I believe everyone in healthcare is here because they care about giving the best care they can. How they're going about getting there sometimes bumps into each other and actually is counterproductive. And it's because we have not, again, sat down and said, what are we trying to do today? How are we going to measure that? And how are we going to know that we're actually succeeding? So do we have a system from a patient's perspective? And I think some people get a bit upset, but I like using the word customers as much as rather than clients. Customers in parts a very different relationship, and we need to look at this from our customers' perspective because really that's why we're there. We're there to provide a service to these people. We're a huge service industry, and although we have a specialized body of knowledge and we know some things that other people don't know, we also know we think we know what the patients want and what they'd like us to do. And oftentimes when we actually look at that, it's not true. And getting to that agenda is often something we miss. And by doing that, we actually are not providing the care or the needs of the patient. And I'm just going to start with a quote on this because I think this summarized it very well for me about how we do not have a system from the patient's perspective. And this is from an email that was sent to me about from a friend of a patient that had been admitted into our hospital who had a TIA and then had gone home, was supposed to be going down to the stroke unit, and unfortunately before she could get down there had had a non-TIA, a stroke, and then was admitted here. This is a fairly long piece, but I'm just going to go through it because I think it is I think it's fabulous. It just summarizes some of the problems we have. There's a bit of an introductory paragraph and says, this stroke was completed as opposed to evolving. Working from that assumption, we had thought that the condition that she was in on Sunday when I convinced her to go to the hospital again would serve as a baseline for her recovery. At that time, Jean was moving slowly and was experiencing some unilateral weakness. This is from a friend that's actually an ex-physio. So unilateral weakness and consequent balance issues, but was in fact mobile and functional. I should note at this time that although I have assessed cognitive function in thousands of patients, I was not seeing any cognitive deficits, but rather felt that Jean's great intelligence, personality, and memory was fully intact. She has now been laying in the ER bed for almost 40 hours, essentially laying in the same position, and we are finding it difficult to understand how this will further her goal of returning to her former self. A few days ago, Jean was actively striding through the neighborhood, giving joy and hope all around her, helping others with their ailments, encouraging children to read and learn at the library, and generally making a very positive contribution to society through her selflessness, caring, despite her age. We were terribly afraid that this continued immobility she is experiencing in the ER will contribute greatly to future disability, and we're wondering if beginning physio is contraindicated as a result of her atrial fibrillation and current meds. And if not, perhaps you could facilitate immediate measures to help any further deterioration. I hope you won't take this following as an insult, and hope you will note that I'm including myself in the following, but I'd like to comment about the fact that in the stress and complexity of the medical field, and certainly observing the current challenges in the new ED, it is possible for us to lose track of what the patient is experiencing. I would ask that we reintroduce how it might feel as a fully cognizant, intelligent individual to be locked in a body that was working, admittedly not as well as a week ago, but still working upon admission, and now feeling even that mobility and independence dwindling. Personally, I can't imagine how horrific, how terrifying and depressing it would be to be locked in a prison, which was formerly our fully cooperative body. Let's let that sink in because I think and that's not an unusual experience. This slide is talking about the Apollo program. Now you're thinking, God, Digney, how do you go from somebody having a stroke laying there decompensating to the Apollo program? Well, my point is to get back to that comment on a common goal. This was one of the most incredible technological achievements probably that humans have ever done. In 1961, it was announced that they were going to put a man on the moon. In 8 years, NASA succeeded in that goal. At the time, they had never even had an astronaut in orbit. At the height, this organization employed 400,000 people and was supported by 20,000 industrial firms and universities, and had an incredible setback in 1967 when they lost a spacecraft and the entire crew. So how did they do that? And in reading about that program, it was their focus. And the myth and the legend is the reporter that was going through interviewing the chief and interviewing all sorts of people at the big NASA headquarters. And he as he was walking along, he ran into a janitor that was sweeping the hallway. And he said, well, what are you doing? And the guy looked at him and without breaking stride said, I'm putting a man on the moon. Every one of those 400,000 people had exactly the same goal. They each had different components and different pieces to it, but they were absolutely fully aligned, and that's how they were able to accomplish that kind of success. So if we look at our quote-unquote system that we have right now, we have a number of different pods. I always put parking in there because that's almost everyone's first exposure to our healthcare system, and it needs some work. And let's just pretend they come to the ED, and then they'll go to X-ray, and then they might have some lab work done, and they might get admitted to a medical unit, and if they've had a stroke, they might go to rehab, and hopefully they go home. So each of these are little pods or little silos, and I think for the most part, most of us can imagine there's usually a manager for each one of these areas, and there's different skill sets that are involved. And really, from a patient perspective, what we would like to see is the patient just smoothly move from one to the next. Organized, clean, simple. We know exactly when it's going to happen, how it's going to happen. We can pretty much predict how often people are coming in and what they need. It's actually not as variable as we all think it is. So we should be able to predict this demand and then match things to in a systematic way to provide that kind of pathway. I think most people's experience is slightly different. They tend to come in, they circle around the parking lot, they can't find the meter, they don't really know where they're supposed to park. I mean, this morning as I was meeting our crew here, there was somebody that walked into completely the wrong side of the building, was trying to find diagnostic imaging, and I had to send her for a fairly long walk to find it. They'll go to ED and then they'll go to lab, and they might sit outside waiting for their x-ray for maybe 45 minutes or an hour before they finally get that done. And we all know this. Anyone listening in, you know this is exactly what happens, and there's a lot of waits and a lot of frustration for everybody, mostly the patients, but including staff. We are excellent at what we do in our silos. I think we do a very, very good job. The analogy, and I'll get to the slide in a minute, is we are 100-meter sprinters. So emergency, when you come in, holy smokes, most of the time we've got our systems pretty slick, and we come off the start blocks and we race down that track and we hit the finish line. And same with medicine and rehab and the surgeons, and we all do our pieces. The problem is what the patients actually need is not a 100-meter sprinter, but they need a 4x100 team. So they need each one of those pieces to work together to get that baton all the way around the track. And it's in these handoffs, and it's when we try and move somebody from one piece of this system or one piece of the hospital or one department to another when things tend to go wrong. I think of the QAs I've had to be part of, and almost always it's some kind of breakdown between groups when things go wrong. So, this was just driven home to me at the Olympics just this summer where, these guys are superb sprinters. But where did every single team that screwed up, where did they have their problem? When they tried to hand off that baton. And we do this every day. Our hallways are littered with batons. We have to wade through the buildings trying to get through them all. They're just piled up everywhere. And it's because we often don't talk about this. We don't practice it. We don't sit down and say, geez, medicine program, I'm seeing 5,000 chest pains this year. How should we manage them? Yet, every one of those patients usually goes from one of us to the other. But we don't talk about it in a logical, organized way. So when it's 2 a.m, it just happens. I don't have to bug somebody. I don't have to argue with somebody about whether it's an appropriate patient or not. Yet we spend enormous amounts of energy trying to dodge around this all the time because we haven't done it in a logical kind of way. So what does this mean to the patients when we don't have anything that's systematic and moving? So we're lucky in 2013 that there's been a body of evidence growing over the last decade about the kind of impact this is having. And I just want to go over I think of the most important papers. So this is from 2006 in Australia, 45,000 patients. And what they looked at were the times of day when both the hospital and emergency departments were considered to be over capacity or congested. And they looked at congestion rates in the hospital starting at around 85% and going up. And in emergency departments, it was when 20% of the stretchers or more were blocked with inpatients. I don't know about everybody listening in, but I know last year Nanaimo's occupancy was 102% on average, and we never have less than 20% of our stretchers blocked. So from this data, they were able to come up with a hazard score for an overcapacity hazard score. And if you were at the maximum score, which we've been running for the last year, we would see 2.3 extra deaths per 1,000 admissions just based on the overcapacity. So for my site, that's 17 patients last year that had a preventable death due to just overcapacity. And I compared that to the C. diff outbreak we had a few years ago when 3 patients died, and holy smokes, there was 2 different reports written. We had cleaners scrubbing the place from top to bottom, and there was an enormous amount of energy, time, and focus put on the problem. And we've been barking about this overcapacity for at least a decade, I have, and I have not seen, although it's starting to change, that same kind of focus and attention paid to this problem. But it is huge. Looking at Canada, This was just looking at what happens when we leave people laying around in emergency departments. Nobody likes it. We all can agree that you wouldn't like it. It's not very nice, and it's usually been seen as an emergency problem and more of an inconvenience than anything else. But again, the evidence seems to be pointing that this isn't just inconvenience. This is actually costing people in a big way, and it's costing our system and our ability to look after everyone in a huge way. So a delayed inpatient bed of 12 hours or more resulted in a 12% increase in the stay and an 11% increase in cost. So you can imagine that if this was occurring to every one of your inpatients, 12% is an enormous number of bed days in the units upstairs. So if you could shorten everybody's length of stay by 12%, you'd have empty beds upstairs, assuming you change nothing else. So 12% doesn't seem like a very big number, but the impact that would have on the overall capacity of a building to function at any kind of reasonable level is huge. This one frightens me. This is Singer looking at an American study, 41,000 admissions. And again, they looked at patients boarded in emergency departments for less than 2 hours, and those boarded more than 2 hours, did all the usual kind of stuff, making sure everyone had the same age and same this and same that. So independent of anything else, this length of time boarding resulted in what to me is a staggering difference. A mortality change of almost double, 2.5% to 4.5%, and a length of stay increase of 3 days. Again, if you could fix that problem, you would fix an awful lot of problems. But I can't think of too many things that we have on our quality agenda that by fixing it we would reduce the mortality rate by almost 50%. Waiting to get into the hospital is not the only thing that impacts patients' long-term outcomes. So this is Gutman and Mike Scholl and crew out there in Ontario. Little tiny study, just 14 million people visits. Looked at it 4 years. This is all the Ontario hospitals. And they looked at what happened when patients presented to emergency departments that were congested and where there was a delay to actually seeing the emergency patients. And they looked at the 7-day mortality and admission rate. And the interesting thing was they found an increase in both of those for times when patients came into a congested emergency department, and that was for all CTAS groups. So this wasn't just your 1s, 2s, and 3s, but 4s and 5s also saw an increase in mortality and future admission rates. And that started to go up, not at 7 hours or 8 hours, but after 1 hour wait in the delay in the waiting room to get in to see the doctor. So we have a very big problem. It's killing people. It has a defined increase in mortality, and so we need to fix it. So why is this so hard? We're not the only jurisdiction that has this problem. The States has it, Europe has it, everyone has this. All the developing world has a problem. There is some big issues that we need to get around. And some of them, and they're not all, I don't think, related to cost. I think the actual money's there, it's just how we kind of deploy it. So some of these barriers to system design, I've alluded to one of them. I think the way we are structured into silos is a big one. We do tend to look at budgets are assigned to different program areas if you have program management. So, you are measured on how you do for your particular budget, regardless of what that has on impact on anybody else. Good example is we looked at a delay of echocardiograms in Victoria. So the medical imaging department was doing a great job. They were doing everything they were supposed to do, and their budget was looking good. Problem is, medicine was bleeding to the tunes of hundreds of thousands of dollars because patients were sitting around in overflow beds waiting for echoes. So if we'd simply said, we'll spend 20 grand here and bring a tech in and clean these up, we would have saved an enormous amount of money somewhere else in the organization. It just wasn't designed that way so that we could actually find that, and there was certainly no reward for doing that. We also, for the most part, have a single person accountability measure, and I'll talk a bit about that. And that, I think, is a bit of a barrier, and there's some psychology behind that. And I put this out for the physicians to think about who might be listening, but also for our managers, allied healthcare professionals, sort of get a bit of an idea of how docs are thinking in their head, because I think that's important. Because all the workshops and conferences I go to, it's often, well, those physicians. I was just at one yesterday, a big strategic planning meeting, and those physicians keep getting in the way. So I'm going to try and explain why we do that, because there's some pretty darn good reasons. I want to introduce a concept called bed elasticity, and some concept of some resistance to why we don't like standardization and why we should like it, and this lack of common vision. So here's VIHA. Sort of a typical flow chart for almost any organization across Canada. And as you can see, there's lovely boxes that don't touch each other, that all feed up to two people, our VPs, who are supposed to have a handle on everything. And as we were doing some work yesterday around this, there were a few initiatives, and these initiatives just crossed over every single one of these little boxes, yet the boxes weren't talking to each other. So this is a structural issue we have that we really do need to try and fix. I don't have the solution of how to do it. I think part of it is a ability of your organization to put the power to make the decisions in a different place. It shouldn't appear anywhere on this chart. I firmly believe that you need to have an organization that sets the big goals and then says, okay, you guys on the floor, make it happen and tell me what you need. Because I'm absolutely convinced that all of the solutions are sitting in the heads of our frontline staff, and we just need to have the guts to let them go and give them some direction and some support, but let them come up with the ideas. Because I don't know how many great ideas have ended up in an email that don't go anywhere because the people that need to implement it weren't involved, and they don't understand why they need to be doing what they're doing, and they certainly don't think it's worth their time. That's not to say they don't care. Again, I think everyone that comes in this building and any building across this country is there because they actually want to do the best they can for the people they're there to look after. It's just getting that alignment is what we need to be able to do. The single person accountability is an interesting phenomenon. So there is only one group that writes a discharge order in any hospital that I know of, and that is always the physician that has to do that. It's the physicians that drive whether that CT scan is going to get done. It's the physicians that drive whether the patient is going to get admitted. Physicians are a huge driver to almost all of the activity in our present sector. And we are held to a very schizophrenic or competing kind of interest. So we want to provide the best care we can to the people we're looking after. And if you take a step back, it's not just that person that's sitting in front of us, it's also the person coming next. And I heard a great analogy the other day where, you're standing in line at the bank and you're listening to the fabulous conversations that teller is having and just being the best, most customer-focused person they can be, asking how the vacation was and did you have a really great time? And, they're doing great for that patient, for that client sitting right in front of them, but there's somebody waiting 20 minutes behind them who just wants to get the bloody check in the bank. So to that person sitting at the teller, they're doing a great job for that person in front of them, but not for the 16 others that are sitting there trying to get their banking done at lunch. So we tend to do the same thing, and that's our training, but it's also what we're held accountable for. So there is not a court in the land that is going to say to us, the physician says, well, I didn't do this and I didn't do that, and because really, it's really busy, and we really don't have that much money, and I've got to make sure that didn't do that CT scan because we kind of met our quota this month. That's never ever going to get you anywhere. So we are held to account for that individual in front of us, yet our actions impact all the other future patients that we're going to have to come in contact with. So somehow we have to come up with a mechanism that supports the physicians to not only make good individual decisions for the patients, but also make good overall patient system decisions. And that's going to be a bit of a challenge. The other thing we're going to have to ask physicians to do is make different kinds of errors. So there are two main kinds of errors you can make. You can make an error of commission, or you can make errors of omission. So these are just some examples of errors of commission. So I do things for somebody, and bad things happen. CT scanning somebody too many times is not a good thing. Biopsying something that shouldn't be biopsied and getting a bad complication from it. Popping somebody on bed rest that doesn't need bed rest and they got a clot and have a DVT. There's all these kind of things all have some downside to them, but you're doing something. And we tend to err on the side of making errors of commission. Why do we do that? Well, because we're rewarded for doing that. So you are a good doctor. You're a thorough doctor. Oh, he did every test. He was so good. I had a CT, I had an MR, and I had this, and I had that, and I da-da-da-da-da-da. Right? So they were very good. And they put me on 3 different antibiotics, and then after 3 weeks, I got better. So the fact you got C. diff and had to have a big chunk of your colon taken out is really irrelevant. But, they were very, very thorough and did everything they should be doing. So these errors of commission are usually seen as okay because at least you're trying. You're doing something. Isn't that great? Whereas if you make errors of omission, you're the doctor on the right? You're the bad guy. You're sloppy. You cut corners. You can't be bothered. You're too lazy. Why would you do that? So to make ourselves into an efficient system piece and to really get ourselves clean, we're going to have to stop doing some things. But when we do them, we're going to have to do it thoughtfully and carefully and with support. So I've been struggling with, and I'll show you a slide in a minute. I'll wait till we get to that because it's think about this errors of commission and omission when I get there because it is interesting. So here is where there's a problem. So here is the patients presenting to our ED here in Nanaimo. So we see 60,000, and this is the average CTAS score for 23 physicians working here. So you can pretty quickly just by eyeballing this say that's pretty much a straight line going all the way across. And this is over a fairly long period of time. So these physicians are really seeing pretty much the same population. They get equal distribution of shifts. They're in the fast track area. They're in the acute area. So over time, they are going to see statistically the same bunch of people. And I just use the CTAS score as sort of a surrogate to say, yeah, it looks like they're seeing about the same number of people. So let's see what they do for that same group of people. So here's their CT scanning rate. So this is the number of CT scans per 100 patients seen. So this is phenomenal. We go from one doctor who basically CTs every 10th person that they come in contact with, and
Drew,
somebody else that CTs. Yes.
That's true. It's Julian.
Yep.
Could you please answer a question? What's the CTAS score?
Oh, sorry. What's a CTAS score? So a CTAS score is it's called the Canadian Triage and Acuity Scale, and it is a way of sorting patients at the front door. So a CTAS score of 1 means you're very, very sick and need to get seen right now. Basically, you're blue. And a CTAS 5 is you could go to see your family doctor the next day. So what a surprise, the average is sitting right about 3, just a normal distribution. So 3. So we have, that hopefully answers the question. So we have a homogeneous group that is getting a 10-fold difference in their CTs being done. If we look at the admission rate, now I'm not sure what happened to Dr. 9. I guess they just send everybody home. But here we've got about a 2-fold difference in the admission rate for, again, exactly the same population of patients. And this obviously has pretty profound effects. So, I've been asked to look at my group, and I say, well, our admission rate is about X%, and that seems to match up with everything else, so we're doing okay, so we shouldn't look at this. And I think, no, there's something in here. There's no way we could have a 2-fold difference in admission rate and be providing the same kind of care. And I don't know who's right. I don't know if the 9%'s right or the 19%'s right, but somewhere in there, this kind of variation is what we need to lose. It should be tighter than this. I'm just going to shamelessly steal a chart from Grant Innes from Calgary, which even shows this isn't just a physician-specific thing. Here's 3 different sites in Calgary. This is for renal colic. So by diagnosis, as they walk in the door, these patients who effectively have the same disease are getting very, very different treatments. So in one site, they're getting admitted about 30% of the time, and another site, they're getting admitted almost 60% of the time. So if it was me looking at this, I think I would like to go to Site B personally because they're sticking a lot of things into people in Site C. And again, I'm not sure that there's actually a difference in the outcomes, and that's what we need to look at. Standardization people roll their eyes when we start talking about standardization. And part of what we're seeing in that variation is a real lack of standardization. I find that interesting because we all graduated, most of the physicians graduated from one of about 16 med schools. We all took the same qualifying exams. There's basically one textbook that sits in almost every single emergency department, and we almost all go to one of 3 different conferences every year. So we either say hi in Whistler or down in Vegas at Essential. So, we're all going to the same things, yet we behave very differently when we get home. And some of that is around a lack of standardization about how we approach a patient and what we do for them. And I don't think that that's a good thing. I think standardization is a very, very good thing. And the reason why I think it's a good thing is it gives you a benchmark to know where you're at. So, again, of those admission rates, I have no idea who's doing the best job because I don't know what it should be because we haven't sat down and agreed on who really should be admitted into the hospital under what circumstances and then looked for the variation around that to see whether one person's doing a better job than somebody else. Also, standardization lets you get away from having to think about all of those things that you don't need to think about. There are some things that for certain patients, you should just do it. It's basic. It's straightforward. So why do I have to write an order for it every single time? Why do I have to think about doing that? Because the only way I can go from that is down. The only thing I can do is forget. If I remember every time, that's great. That means I'm 100%. But I'm a human being. I get busy. I forget stuff all the time. So what's going to happen is the care will be less than if we standardized it. And my brain is taken up with a bunch of stuff it doesn't need to be, which means I can't focus on those really important things that aren't standard, that I should be thinking about. But we pile it all in one lump sum because, oh my gosh, we don't want to do cookie-cutter medicine. Well, there's parts of medicine that should be cookie-cutter because that way you are providing high-quality care to everybody. And interesting, the sites in the States did a review of who had the best outcomes for heart attacks, for AMI, and the sites that did the best were the ones that were consistent in giving aspirin. Not having cardiac catheterizations or their door-to-balloon times or any of that kind of stuff. It was the sites that nailed the basics perfectly all the time. So the way you do that is through standardizing workflow and standardizing what needs to happen, and that's how you're going to try and get to that level. So let's talk a bit about elasticity. So this, I throw this out as a tester, so in the discussion, if you think I'm completely off my head, let me know. But this kind of came to me a little while ago when there was an event that happened here in VIHA, and it got me thinking. So this is an economic term. So it's when you change one thing, does it change something else? So as you increase the price, does the demand go up or down? It's that whole economic idea. So I've changed it around and called it the concept of bed utilization elasticity. And the definition for that is a tendency of the length of stay or the utilization of a bed to change depending on the real or perceived medical need for inpatient hospital care. I don't know how many times in my career I've heard somebody say, are there any beds? Why would that ever influence your decision to admit anybody? They either need to come into the hospital or they don't. If there's a bed or not, it really shouldn't make a difference, in my opinion. So what the capacity is in the building is irrelevant. It's either there or it's not. And we know even when there aren't beds, we still admit people, so why should it matter? So let me give you some real-world examples of bed elasticity. So this is for VIHA, and VIHA's been working very hard on getting the ALCs the alternate level of care. So the patient that's sitting in the acute care beds that don't need to be there, because part of the concern was, well, the reason why we don't have any capacity is because all these ALCs are just plugging up our beds, and if we could get rid of them, then we'd be in a great position. Everything would be fabulous. Well, people have worked very, very hard in this health authority, and as you can see, they have dropped the ALC rate in census, has gone down. So in 2009-10, we were sitting around 200, and they've dropped it down to about 150. What happened over that time period? The ALC improved, but the census actually stayed exactly the same. So what we did not see was an improvement. That those beds were taken up by something else or somebody else, and the little line on the bottom is the poor old ED down there basically still holding all of those patients because we didn't change anything about how we flowed the patients from one part to the other. A slight decrease, but it's bouncing up and down. Sorry. There we go. So this was fascinating. So in last year, something called the PCC, which is the Patient Care Center in Victoria, opened. And part of the planning for that was to say, gosh, poor Royal Jubilee Hospital down in Victoria, they always have 30 inpatients, chronically stuffed to the gills with 30 inpatients. So if that's the real norm for the amount of medical patients we have in the building, so whoever's upstairs plus the 30 downstairs, then logically, if we add 30 more medical beds to the bed base in the tower, then we should solve the emergency problem, right? Because for 5 years, we've always had 30 inpatients. We'll add the beds in upstairs. Okay, so that's those 30, so that should do it. So what happened? Well, we added the beds, we opened the new PCC, and within 5 days, we had 20 more inpatients clogging up the Royal Jubilee Hospital, and over time, it just gradually came up. So this tweaked me. I said, okay, what happened? What went on? And what happened was the length of stay upstairs increased. So we didn't change anything in terms of the process or the accountability or how people were discharged or admitted. So what this shows is the blue is the pre, the red is the post. The estimated length of stay, or the ELOS, is based on what the patient has there, what kind of conditions they have, and they come up with this number. So on the other side, we've got the actual length of stay, and it basically went up by half a day, so about a 12-hour average increase. And when we're talking about the kind of efficiencies we need in order to clear the beds that we need, in order to move the patients through in a timely manner, we're only talking about a 5 or 6% change in the efficiency, which actually can be measured in hours. So increasing the average length of stay by half a day makes an enormous difference. And it was totally shown by this real-world example. So now I want to get more positive. Oops, I flew through. So I want to get a little bit more positive. So what about a good bed elasticity? What about if you change things and try and improve the utilization of your beds? So this is an emergency department in BC that in 2008 decided that it was actually going to change its processes and use its beds differently, and just reviewed what it was doing. So in fact, increasing populations of patients coming in, so the volume went up over this time period, same physicians working, same physical space, just a reorganization of how they did business. And they were able to basically, if you look at the, say, CTAS 3s, which are fairly sick patients that often need stretcher spaces and time to work, we're able to drop the total length of stay in the department from almost 6 hours to 3.5 hours. And those poor old 4s that were getting ignored before cut it almost by 60%. So this kind of thing can be done. To give another real-world example, and this is getting to accountability and elasticity. It's a little bit complicated, but what you have is a graph of the number of inpatients held admitted in the emergency department. So that's that blue sort of mountain range. And the one at the top is looking at it over months, and the one below is sort of spreading it out over a few years. And there's a spot where things suddenly change, and that spot is actually right there over time. And you can see on the top one, that's the year one on the top, and it just kind of disappears. It kind of fades off and goes to nothing. And then that dotted line is when something called the Psych Emergency Services opened here in Nanaimo. But what happened at that red spot was the psychiatric department had a group meeting. They brought another group from Chilliwack over who had made some big changes and sat down and decided that they were not providing a good service to their patients, and that to leave people without any kind of psychiatric care whatsoever for 2 or 3 days in an emergency department, or worse yet, sending them out of their own home community an hour and a half up north because that's where the bed happened to be, was just not very good care. And they reorganized themselves. They took accountability for the demand coming through the door. And then with the opening of the psych emergency services, we worked together with them. And basically since October the 1st, or actually prior to October 1st, we have not had an admitted psychiatric patient in the emergency department. And in fact, 2 weeks ago, I nearly fell off my chair when on an over-census teleconference, it was a psychiatric manager that volunteered to take two patients off of medicine who were there with dementia-type problems and said, well, look, we'll bail you out because we got 8 empty beds, so we'll take 2 of them downstairs, and that'll free up some room, and then when you got the room, we'll send them back to you. I mean, that is system people working together to look after patients properly. So that's been fabulous. Another, I think, incredible example of what happens when you're focused and you have a patient focus. This is, again, shamelessly stolen from the pediatric psychiatric services and Yana Davidson and her team over at Children's. And they did a lean design looking at the time it was a referral to assessment for their eating disorders clinics. ED is eating disorders, not emergency department. So there is another ED in the world. And their baseline was 66 days. And as Dr. Davidson would say, by the time one of these, and they're a quaternary service, so they're providing the services for the entire province. So by the time these poor people were being referred, they were already 80 pounds and 75 pounds. And we were making them wait another 2 months before they'd come down. And so their goal was to get it from 66 to 7 days, which is the red line. And they not only got it down to 7 days, they now have it down to as quick as they can come. So when somebody calls from Terrace and says, I got a referral, they say, well, when can you get here? Okay, great, 3 days? Okay. So that's why it's not lower. So and that has been sustained over time. So they've done an excellent job. So to sort of summarize and give us a little bit of time here, I think we live in a very complicated world. What we do is difficult. It's not easy. There's a lot of competing demands. But I think there's enough examples out there that if we can be united, focused, and clear on what we're trying to do, there is enough resources and enough staff and enough beds within our present sector to actually create a system that's going to be patient-focused and responsive and provide excellent care. So what we're going to do is I'll turn off my phone and we'll go on to the live here. So if there's any questions, we can hear that. So over to you, Julian.
Thank you very much, Drew. That was an excellent talk and very interesting. I'm just going to, if you've switched over and if you can hear me, just for those of you who are listening, what we want to do is leave you muted until you have a question. And if you could raise your hand, we'll unmute you, and then you can ask your question. We'll do it that way because otherwise we get too much feedback and you can't hear the question. Drew, can you hear me now? Oh, sorry, we have to unmute Drew. So which one, we have to get Drew back and find out. Actually, why don't we unmute everybody? Sorry, just hang on 1 second. We got a technicality. Because we muted everybody and now Drew's gone to another phone, we now have muted Drew in his room. So, Drew, can you now?
Yes, I can.
Just talk for 1 second. Find out which one you are.
Well, yeah, open for lots of questions, and hopefully there was some prodding going on there. The point of the talk was to actually prod people into thinking differently or thinking about things that they hadn't thought about. So there should be questions, and you should be, hopefully some people got a bit irritated. So that's part of the point.
Okay, thank you, Drew. I think what we'll do is we'll mute everybody, and we'll just leave your line open. You can still hear me?
Yes, Drew? I can, and of course Eric has a question. I can hear you. Can you hear me?
Yes, good, thank you. So we've isolated you down. I just wanted to throw in my question before Eric does, just so because I can. I just wanted to. This is an excellent topic, and really is. I think you're dead on, right on, in terms of needing to be able to break down those silos and work as a complete system, which we are not. How would we do that? And so, obviously not in the detail that we can get into here, but how do you think we go about convincing the various interest groups that this is the way to go? Have you?
Yeah, so we've started a trial project here of having something. We started off as something called the Nanaimo Site Operations Council, which was the managers and as many physicians that we can entice to come to sit down and start talking about how we were going to get the building working. And the first thing we did was we set some goals for what a functional building would look like and then how we were going to get there. We quickly realized, though, that it's not about the building, that so much impacts on what we do is what goes on in the community. We've expanded it now, so now it's not the Nanaimo Site Operations Council, now it's just Nanaimo Operations Council, and we actually have people from community, the Division of Family Practice, mental health, and public health are there as well. So we just started that work to see how this is going to work. Shared care has been very helpful. They do have resources there that can be accessed, so we can actually compensate some of the people who don't have paid physicians to come. And it's a working group, all with the shared goal of trying to get the system organized and in some kind of manner. So I think that's the only way to do it. You have to have everyone at the table. It is very complicated.
That's great. And how do you bring them to the table, apart from if they have a position that they should go to the table? But how do you get people to come to the table, sorry?
So the first thing you need to do is make it useful. So we've said it's going to be action-oriented, and we have to get some low-hanging fruit and make some changes quick that people will then see that it's worth their time.
The lean work. Well, I'm just saying, don't forget about all the lean work you guys did to build, which brought some of those people, which gave us.
So it actually, thank you, Sam. So it actually, the genesis was we did 5 works of lean on the designing when we moved into a new department on how we were going to move the patients through the emergency department. And as we did that, we realized that a lot of the things we have to deal with is outside the emergency department. So we had an entire week with seniors there, and we started to see the power of actually having everyone that's involved in that patient's, and I hate to use the catchphrase journey, but really it is, but that patient's exposure or encounter with us, all of those pieces together in the room at the same time, again, working to a common pathway with the patient right in the middle of it. And so that got a lot of people excited, so we're trying to recreate that, but in a bit more organized way.
Thank you, Drew. I'll hand the microphone, so to speak, over to Eric.
Drew, I really liked your talk, and I wonder, I like the concept of the patient focus, the patient as a customer, and I wonder how you square that when the patient's interests may compete with the staff interests or the physician interest. And I know that you did an experiment in your department where you shortened the physician shift in order to improve the time to physician. It was successful, improved the patient experience and the outcome, but it wasn't sustainable. And so how do you go about navigating, what benefits the patient, what benefits the staff?
Yeah. Thank you, Eric. I think at the bottom of it, now that was one interesting experiment that we knew was not sustainable before we started, but we just wanted to see what happened. What Eric's referring to is we shortened our shifts down to 6-hour shifts, which meant everyone was here almost every day. But we dropped our door-to-dock time down to about 23 minutes. It was quite impressive. But I think at the heart of it that if we have a truly patient-focused system, that benefits staff. So wouldn't it be, and as I say, where do we run into the rub, right? What part of your job drives you crazy? Well, mine is I need to admit somebody, and I'm trying to figure out, who's going to take them, and I get into a different, and it depends who's on call, right? So one night it's no problem, the next night it's a pain in the butt. And another time, so I think a lot of it, if we had a system where I could say, Mrs. Jones, yes, you have a broken ankle, and you're going to be having your operating room. It'll be at 8:30 tonight, and Dr. So-and-so will be here, and we'll run through all of the risks and complications with you in 15 minutes, and you will be discharged, and we could hand them basically a piece of paper that would tell them exactly what was going to happen, when it was going to happen, and how it was going to happen. That would be fabulous. And I think, one of the, if we think about the way we do things now, so if I said to you, and this is the craziest thing, if you came to see me, I'm your GP, Eric, and you came with a lump, and I examined you, and I said, okay, fine. I went out of the room, and I came back in, and I said, tell you what, we're going to get your CT done in 2 days, and I'm going to have you in to see Dr. So-and-so on Friday. Are you happy, or are you worried? You're worried, right? Because what that says is you've got something really bad. Where if I came back and said, yeah, your CT is going to be, well, I sent the rec in, they'll call you. Well, maybe they'll call you next week. I'm not actually sure when they call, but they'll call you, and then I've sent a referral off to Dr. Jones, and his office will get in touch with you. Oh, when? I have absolutely no idea. It'll be sometime later. All of a sudden, if I'm a patient, I'm relaxed, right? Because this guy clearly isn't worried what's wrong with me. So we have a system that if we're responsive, it's bad news when it shouldn't be that way. The norm should be that when things are going to happen.
because we know they're going to have. So that's it's just an example of how messed up and backwards our system is right now, or lack of system.
Great, thanks, Drew. If anybody has any questions, I remind you, please notify us by pushing the hand icon and or typing in the chat box, and we can bring that forward to Drew.
There's a chat box here on, can you please share how involved the physicians are in alignment with access and flow throughout the hospital? It's variable. Not as much as I would hope at this point. So certainly in the ED itself they are, and we've that little emergency example was ours, and you can see the results that had. The psychiatrist, the fundamental change in that flow was the physicians getting on board and being involved and recognizing that they had a responsibility, and you could see the dramatic results that had in terms of moving patients through. So there are pockets where they're very involved, and when they are, it's incredible the results. The children's example was again involved with physicians and being there. So part of that challenge is time. We have a shortage in general of almost every specialty in every group in almost every hospital. They're all flying around, working their cans off and working ridiculously long hours and up all hours of the night. And we don't have a reimbursement system that actually reimburses physicians for doing the administrative roles of sitting down and taking that big picture approach and working this stuff out. It's seen as bad if you would pay them the same as what they would make, doing their clinical work. And I would actually argue, of course, completely selfishly, that it's the rare bird you get, which is a clinician that also can be an administrator. And if you find that person, then you should grab them and you should pay them probably more to actually do that administrative work, because it is so incredibly valuable. It's the only way we're going to get to a true system, is if we have all of the players at the table equally bought in and playing and working hard. And there's no one else that can talk to a group of physicians like another physician, unfortunately. It's just the truth. So you absolutely have to have that background in order to understand where they're coming from. As I say, this whole errors of omission, commission piece is something that I think everyone needs to understand, that we're held to sort of a very funny double standard that we need to understand and appreciate and not fight.
Excellent. Thank you again, Drew. Anybody have any questions they'd like to ask? I don't see any hands. Is there any?
What was the reason for increasing?
Drew, can you? I don't know if you see the text, but what was the reason for the increased length of stay after the patient care center was opened in Victoria? Do you have a sense of what happened there?
I have no idea why that happened, other than it went back to its old steady state. So whatever pressures were there before were the same pressures, positive or negative, after. So what should have happened was, the day it opened and they moved the beds, they should have said, we will never hold an inpatient in emergency again. They will all go upstairs, period. And that's it. That's the rule. And that would have solved the problem. But we didn't. What we did is we just said, well, it's just whatever. Yeah. And it just changes. I got asked why, we see 60,000 a year. I have 4 ambulance offload areas. That's it, 4. That are almost always empty. And why is that? Because we don't hold people on stretchers. We move them. We put them somewhere else. And then we push the pressure. We put them into an empty bed. And we've just, did it start today? I should know this, but then we just started a policy where Emerge will always have 1 empty stretcher no matter what. And that was sitting down working with the various managers throughout the building, because the question really was, okay, so your kid comes out of the back door at home, he falls, he slips, he smashes his head, and he's unconscious. How many empty stretcher beds would you like in your emergency department when you come in? And the universal answer around the table was, well, at least 1. So that's where we start. I think it should be about 5 or 6, but I was happy with 1. So when you ask the staff who are running the various units what they want their emergency department to be, they can't argue with you anymore. So we will now always have at least 1 empty stretcher, and that's not including our trauma room.
Drew, I think we have It's 1 o'clock. I'm going to try and squeak in one question from Ray Hill. Ray, if you're still there, we're going to unmute you now. Okay, Ray, go ahead, please, with the question. Ray, try one more time if you're still there. Okay, looks like we've run out of time, so I'm going to say again, thank you very much, Drew. This has been an excellent talk and really stimulating. Lots of good information there. So really appreciate your time and effort on this, and thank you everybody for attending. Our next webinar will be in 2 weeks when we have the panel discussion on health system accountability, what, who, and how. And I remind people that there's a sepsis talk this Monday at 9:15 webinar at the same BC Patient Safety and Quality Council. And please think about coming to WEDOC and April 26th to 27th. And finally, the Quality Forum at the end of February. So again, thank you much, everybody, and have a great day. And thanks again, Drew.
Pleasure.
So Drew, my question was